Hi, everyone, and thank you for joining us today. I know people are still trickling in, but we have a really great panel. So I want to go ahead and get us started. My name is Michaela Jackson, and I am the Program Director of Prevention Policy for the Hepatitis B Foundation. And today we're going to be talking about community collaborations with health departments for hepatitis B prevention. As I'm sure a lot of you know, August is National Immunization Awareness Month, so this is a perfect time to be talking about these types of collaborations and what we can do to prevent hepatitis B. So just a few housekeeping items before we get started with the great panel. All attendees are going to be muted right now, but you can always just shoot a message in the chat to one of us directly on the panel or in the whole group in general. If there's any questions, please feel free to drop it in the Q&A or the chat box as well, and we will get to those questions at the end. And the session is being recorded as well, and we are going to be sending around the slides. So if you think of a question later on, you can also have all of everybody's email addresses saved in the PowerPoint as well, so you can follow up with anybody with any questions that you have. So a little bit about our hosts today. Hep B United is a national coalition, and we are 50+ local organizations across the United States. As you can see on this map, we are incredibly spread out. We have a lot of great partners across the US, and a lot of them do a lot of great work around prevention, treatment access, and linkage to care for hepatitis B. They're in multiple states. So if you guys have any questions or need hepatitis B assistance in any of the states that are down there, please feel free to reach out to us, and we're happy to connect you with those on the ground. And with that, I can turn it over to our co-host today to talk a little bit more about their network.
Great, thanks, Michaela. Hi, everybody. Thanks for joining for the hour today. I'm Jasmine West, she, her pronouns. I'm a manager at NASTAD's hepatitis team. And just really quickly, if you haven't heard of HepNet, I thought we could give it a little plug here. It's the Hepatitis Network for Education and Testing. NASTAD and its partners, NVHR and NACCHO, we're building out a network of public health partners, community-based organizations, tribal organizations, people with lived experience, healthcare providers. We have a lot of other key players involved, all specifically focusing on identifying and addressing the unmet needs of people who inject drugs. And this is, again, primarily focusing on improving their access to viral hepatitis education, prevention, testing, linkage to care and treatment. Specifically, we do have Hepatitis B Foundation as one of our primary partners. It's ensuring that HepNet's not solely focused on HCV, but that we're also intentionally including HBV. So you will be able to access the links on the slides, as Michaela mentioned, but I'll also try and put them in the chat box. Next slide. So with that, we're going to jump right in. We'll be hearing from awesome panelists today in the order that you see here. So we'll start with Hep B United Philadelphia, followed by National Viral Hepatitis Roundtable and NVHR, and hearing from HBI DC, and then lastly, we'll hear from NASTAD to wrap it up. We'll have some time for a Q&A at the end, but you can also feel free to include your questions in the Q&A section. And we'll just jump right in with that with Hep B United Philadelphia, and I'll ask the panelists to introduce themselves.
Thank you. Hi, everyone. Thank you for joining. My name is Evangeline Wong, and I'm a public health program manager at the Hepatitis B Foundation. And today I'm joined with my colleague, Catherine Freeland, Associate Director of Public Health Research at the Hepatitis B Foundation. And today we are going to talk about our collaborations within our programming. Next slide. So this is a brief outline of our presentation today. Next slide, please. So a little bit about us. Hep B United Philadelphia is a locally owned, community-owned coalition that was created to increase hepatitis B testing and vaccination in Philadelphia through public awareness and education. It is led by the Hepatitis B Foundation, and we currently have over 70 coalition partners, including the Philadelphia Department of Public Health, university health systems, social service providers, healthcare professionals, nonprofit advocates, community organizations, and providers of human services to Philadelphia's Asian American, Pacific Islander, and African immigrant communities. Next slide, please. So we provide hepatitis B educational and testing services with our community partners. We also conduct international, national, and local research on the lived experience with people living with hepatitis B. And this explores barriers to care, discrimination, quality of life, and more. Next slide. Our first partnership example is from a recent Test and Vaccinate event in collaboration with the Philadelphia Department of Public Health and the African Culture Alliance of North America, ACANA for short, and they are one of our local community partners in West Philadelphia. Next slide. So we were able to collaborate with the Philadelphia Department of Public Health, or PDPH, to provide vaccines. Our partner at PDPH was able to leverage the emergency response team administering COVID vaccines at our event, and they were able to add on the first dose of the 2-dose hepatitis B vaccine. They were able to administer the hepatitis B vaccine as long as that COVID vaccine option was present. So as you can see, our test and vaccinate methods on the left side of the screen were intake. So completing our screening forms, including a demographic and risk factor assessment and informed consent. And then we tested the individual, and then we gave them that option to get the first dose of the hepatitis B vaccine. For those that got the first dose of the hepatitis B vaccine, we provided information and resources for their second dose and where they could get it locally. We worked with the health department to create this resource so people could have options that work for them at local pharmacies where we knew the 2-dose vaccine was available. And at the event in the previous picture, we created a natural flow in our partner ACANA space to ensure that people would be able to get tested first and then vaccinated in order not to mess up our test results. At the event itself, we were able to test 32 people in about 4 hours at their site. Of those individuals tested, 1 tested positive for hepatitis B, and 12 needed the vaccine, and the rest were protected. And all 12 individuals received their first dose of the vaccine, and some people even received both the hepatitis B vaccine as well as their COVID booster. So during that event, the health department was also present, obviously, and they were able to insert people into their PhillyVax database, which tracks people's vaccine completion. So we are, after this event, we followed up appropriately for individuals needing care or the second dose of the vaccine. We are planning a follow-up second dose vaccine event at ACANA's site in early September. Prior to that, we will send out texts to individuals that need the second dose to remind them of this event. And just of note, these vaccines were provided for free as they were purchased through a larger LMH grant focused on hepatitis B. And Catherine will talk more about this grant in a minute. Next slide, please. This is the resource and information we were able to hand out at the event. So we gave individuals these cards as follow-up with their copy of their test results and a letter explaining their test results with the next steps. We hope this card makes things easier and helps people interpret their results and help keep them on track for their hepatitis B testing dates and vaccination series. This model is important as we look toward new guidelines of hopefully a universal one-time hepatitis B testing, and it also incorporates that universal vaccination guidelines that were recently released this past year. Also, this is a flexible model, so your organization doesn't necessarily have to collaborate with a health department. You can collaborate with other partners like pharmacies to implement this test and vaccinate model. I will now pass it to Catherine to talk about our other past collaborations. Thank you.
Thanks so much, Evangeline. I just want to highlight a few more examples that have proved to really be successful projects and collaborations between our work with the Philadelphia Department of Public Health. And I just want to also shout out, I know there's some partners from the health department on the line now that have been really instrumental in making sure that hepatitis B is prioritized at the city level. And I think this prioritization wouldn't have existed had we not really worked to establish this long-standing relationship with the health department. And it's really been a two-way street in terms of communication and connecting with one another, updating each other on what's going on, and trying to find ways of opportunities for collaboration and research. And I'll talk a little bit about some of the areas now. One thing I've worked to do is really find and identify opportunities to apply for funding together. We all know that hepatitis B is really under-resourced, both at the state, local level, and also really thinking about at the community level. So we worked when the Office of Minority Health published their RFP for demonstration projects for elimination. The health department really reached out to us and jumped on it. They convened other partners within the city to really help us work together towards creating this model for sustainable change and elimination in the city. We've also partnered on a variety of research projects. I'm just going to highlight a couple here, but I think the more opportunities that you can find to connect and collaborate and include the health department in your work, the more they'll understand your work that you're doing, and also the more they'll think of you when there are opportunities for funding and supporting resources. For this Office of Minority Health grant, we were a subcontractor for the grant. The funding went directly to the health department, and there were also other partners involved to really think about this in a sustainable way. Really, one important tidbit is making sure that we have open communication about the work and updates that are going on in our spaces. It's easy to get siloed into our own objectives, but I think making sure that there's ongoing relationship building and communication is important. We also update the health department when we're going out into the community about our different events, and we invite them to come along with us and help volunteer as well. And we always share resources with one another. We'll bring the health department's resources. Oftentimes they may have a language that we may not have available, and so we'll use that in our outreach activities and events, and vice versa. So they'll use some of our content as well for their outreach. And we always work together for linkage to care methods. Next slide as well. Okay, so the OMH grant focused on these main pillars that you can see in this figure here, really working to create sustained change in infrastructure within Philadelphia. The goals were to really reduce morbidity and mortality and to reduce barriers to care, testing, and our work as a subcontractor focused on the community outreach setting and really networking, bringing partners from the community to the table. We also started a provider training program called Project ECHO, which trains primary care providers on hepatitis B using didactic learning and case-based methods program, which really has created a positive outcome for both us, and it strengthened our provider champions and referral network. So not only from our community-based testing, like Evangeline mentioned, we have providers that we can really refer to. The health department also has resources for their referral as they're doing patient navigation for a variety of their programming. This is something that's for both of us. Next slide, please. Another example that from a Philadelphia. This was really to understand the prevalence of hepatitis B in Greater Philadelphia, and through hepatitis A, the department took the lead. Sorry, I think. Sorry, guys. Are you able to hear me now? Okay, perfect. Thanks. So the health department took the lead on the diagnostics and the testing, and then we helped with the hepatitis B specific testing and the linkage to care and some other resources for hepatitis B specifically in this, and also helped with the write-up and follow-up. This really helped us see the burden of viral hepatitis within this specific population and started to serve as a jumping off point with how we can work to address hepatitis B in this community. And we also were able to really establish new partnerships and relationships from this. And this is something that's ongoing as well. So I think once you start to find a way or a project that you might be interested in collaborating on, it will often open the door for new opportunities and ideas for projects and other programs that might fit both of your goals at the end of the day. Next slide, please. So I just wanted to leave you with a few suggestions on how you can work with your local health department or strengthen relationships that you have with your health department or even other organizations or potential partners. Note that it does take a lot of time. From the inception of Hep B United Philadelphia, the health department was at the table with us and helped in strategic planning from the beginning. We also make sure that we're present at their HepCap meetings, so their coalition for hepatitis C in the city. We make sure that we're there and supporting their events and activities and also stay up to date on what's going on. For our meetings, we often provide an opportunity for the health department to have a space to share their updates and activities, both so we can understand what's going on from their perspective, but also to understand how we may be able to play a role and help guide their strategic direction. And also, making sure that the health department sees you as a resource in the community. We are often at the base and working in the trenches with the community partners themselves. So making sure the health department can see you as a resource is really valuable. I think that our Philadelphia Health Department sees us as that. In our leadership in the community advisory board that we have in Philadelphia, which is a bunch of stakeholders at the community level. So making sure that you're a trusted resource to them is really helpful. And you can certainly do that by continuing to maintain a relationship. I know sometimes with health departments it can be difficult because sometimes there's turnover, but doing your best to try to maintain that relationship is really important. It does take time and champions. In the inside, we've certainly had our luck with the Philadelphia Health Department as being amazing and seeing the value and making sure hepatitis B is at the table. But ultimately, we can't reach goals of elimination without this type of collaboration. And we know that we wouldn't be able to do what we've been able to do in Philly without the support of the health department as well as other partners. So just want to leave you with that. And I believe our contact information is on the next slide. If you're interested in learning more about some of our programs or getting in touch with Evangeline or me. Thank you so much.
All right. Thank you for that, Catherine. My name is Cass Botts. Hi, everybody. I'm with the National Viral Hepatitis Roundtable, and I am the Coalition and Capacity Building Manager for NVHR. I work on the HepNet initiative that Jasmine had mentioned earlier. And I don't have any slides. This is going to be more of a storytelling time. I'm just going to briefly talk about an experience that I had in a previous position, actually, in a harm reduction setting that kind of just illustrates how health departments and community members can, from a perspective of kind of like a philosophy of the lived expertise of community members who are either at risk for viral hepatitis or who maybe have lived experience with it. That philosophy can really guide the partnerships and programming that gets implemented in a way that just makes it shake out where there's rapport with community, where the programs are just better, and where, I think moving even just beyond the harm reduction setting, you can apply this philosophy to working in any kind of viral hepatitis care. So my background is actually in working in harm reduction provision of services. So I was the executive director of the Indiana Recovery Alliance, which is based out of Monroe County, Indiana. It is a statewide organization, but it really does direct services and operates an SSP, a Syringe Services Program, on behalf of the Monroe County Health Department, who kind of contracts IRA out to do that. And so in Indiana, you may be familiar with Indiana because of the Scott County HIV outbreak. Bloomington's just about an hour north of Scott County. And so, in 2015, the SSP law went into place. And that really states that, with county or city approval, a health department can kind of own the operation of a syringe services program. And that's tended to be how it's gone in the 8 counties that have programs. There are 92 counties in Indiana, by the way, so severely lacking because of the way this law is set up, I think. But the thing that Monroe County did, which is where our SSP is based out of, that's really special, I think, and which should be a model, I think, is to contract out with folks who had already been doing the whole time that kind of grassroots harm reduction services work, and was made up of people who use drugs themselves, was made up of people with lived experience with hepatitis. It was made up of directly impacted community members who were the leaders of that initiative. And so shout out to Penny Caudle, Kathy Hewitt, Melanie Vestlage at the Monroe County, Indiana Health Department, because they really value the lived expertise of the people who had been doing the work the whole time and who knew what the risk factors were like from the position of having been a person at risk or with lived experience with, for the most part, it was a lot of hepatitis C work. And so after I, share this story, I'll pass it off to Amy, who will talk a little bit more specifically about Hep B. But, partnering and contracting with an organization made up of and led by directly impacted people, I think allowed for just instant community rapport and ultimately better services all around. And so some examples of things they did really well were they had at the Monroe County Health Department a harm reduction specialist position. And that harm reduction specialist would be at the SSP, which was operated by the Indiana Recovery Alliance, and was able to build that really direct community rapport with participants by kind of just being there all the time. And in that, it wasn't like, oh, this is the health department team just suddenly coming into our space where we were feeling safe and now we're feeling a little on edge because healthcare makes us feel kind of, iffy because of past experiences. It wasn't like that because it was an individual who was dedicated to being in that program and offering that kind of support. Another thing they did that was really great was they had an advisory council, and the advisory council was made up of invested community members who were stakeholders, whether they were participants of the organization or folks who were working at the AIDS services organization, things like that. And that advisory council being made up of community members allowed for strengthening of community partnerships, not even just in the realm of like rapport with participants, but also being able to leverage other partners for things like, public health nurses who contract with the health department, being able to come in and partner with the ASO to offer Hep A, Hep B, and COVID-19 vaccinations. So all really good examples from the harm reduction perspective. And I think that, one of the things that HepNet, which Jasmine mentioned earlier, is trying to do is provide opportunities for learning communities where jurisdictions will be able to apply to participate and be taught and facilitated by people with lived experience who we are currently training up to become consultants from the perspective of lived expertise. So we're really trying to foster this idea of the community members who are directly impacted being the experts on, what the best ways to go about providing services are according to their perspective. You have the public health expertise, they have the this is what my life is like and what kind of barriers I face in my day-to-day expertise. So I just wanted to plug real quick that if this concept sounds great to you, but you might not really have those strong partnerships and rapport with community, then please look out for the opportunity to sign up for those learning communities for HepNet. And we encourage people when they apply to also bring on a community member with an experience, if you have someone you're close to already, to be a part of that learning community alongside you. And again, that was a little bit more vague. So in order to talk about Hep B more specifically, I'll go ahead and pass it to Amy.
Hi, everyone. This is Amy Trang. I'm the interim program manager at HBI DC, which many of you have already heard about and worked with closely with the executive director, Jane Pan. I'm going to put in the chat box our website if you want to get some pictures, because I don't have slides today. I want to tell a story, just like Cass did about HBI. So HBI, we were founded in 2006 as the Hepatitis B Initiative of Washington, DC. And HBI is a 501c3 nonprofit organization with an updated mission to mobilize communities to address health disparities, including preventing infectious diseases and liver cancer by detecting hepatitis B, hepatitis C infections early that affect the vulnerable populations that we serve. We are really a grassroots organization that depends on collaborative partnerships to provide culturally and linguistically appropriate outreach, education, screening, testing, vaccination linkage to care and patient navigating services for our impacted communities to promote immigrant health equity. And annually, HBIDC, we have the capacity to outreach and educate and screen and test, and as well as link over 2,000 individuals to healthcare and treatment services throughout the Washington, D.C. and Baltimore, Maryland metropolitan areas. So that covers D.C., Maryland, and Northern Virginia. Our team includes multilingual staff that collectively we speak over 9 different languages, in addition to English, and that includes Amharic, various Chinese dialects, such as Mandarin, Cantonese, Shanghainese, French, Korean, Mongolian, Vietnamese, Yoruba. We also have volunteers among our teams who speak Burmese, Cambodian, Laotian, Spanish, Tagalog, which is, the language that the Filipinos speak, as well as Thai. So if you haven't heard the HBI story, our founder or co-founder, Leslie Oshu, well, she was a student at Harvard. She found out that her younger brother had hepatitis B, and not too long afterwards, he passed away. And then about a year later, her mother also passed away of hepatitis B. And so she was determined to raise awareness about hepatitis B and get people screened and tested. When she and her husband, Thomas, moved to the DC area in 2006, that's when they actually started HBI DC. And then in 2009, Jane Pan was asked to be the executive director. And I have to tell you, she only had a budget of $5,000 to do this work. At that time in 2009, I was working for a local county government in the Area Agency on Aging. And Jane was my volunteer at the Area Agency on Aging. But when I left the county in 2013, Jane asked me to help her expand HBI from a budget of less than $100,000 a year to now we have over $500,000. I would say last year it was like $750,000 or more in terms of an operating budget. And we quickly learned that the importance of sustainability for a grassroots nonprofit is flexibility and the ability to work with other community-based organizations as well as the local health departments. We work with DC Department of Health as well as the Maryland Department of Health. And because we're in Northern Virginia, we work with the local county health departments like Fairfax County, Arlington County, Prince William County. And it's so important that we are able to leverage resources from our county health departments as well as the state departments of health, because there's, as you know, if you do hepatitis B work, there's not a lot of funding out there specifically for B. So in 2013, we also had to expand and start education and outreach for hepatitis C and screening and testing for hepatitis C. And then in 2016, we had to also expand to HIV. In actuality, it wasn't that we had to expand to HIV, it was because we were asked and invited to work with those vulnerable populations that we were already reaching to and to have them get screened and tested for HIV. So the work that we have been able to do in the Hep B world demonstrated to our health department partners that we had the capacity to really reach out to these vulnerable community-based organizations. Our clients are usually those who have no income or low income, little or no health insurance coverage at all, or they may be underinsured. as well as limited English proficiency. We do not have a clinic, and so we have what we call like a mobile unit based model where we actually bring our team to local community events, church events, community gatherings, whatever it is that people invite us to, we're there. If it's a safe environment, then we will set up our screening stations and screen and test individuals. But if it's a situation where we feel that it's not safe to screen and test because of all the sharps that we have, then we will just do outreach and education. But I have to say that, you know, we have a tremendously capable, wonderful team that we work with, and that's how the health departments know about our work, because they see us in the community, and they also see the numbers that we report each month. And so we are very fortunate to have that partnership. We are also invited to the table to be a part of the elimination plans in Virginia and Maryland, as well as participate in the Maryland Hepatitis Coalition, as well as Virginia Hepatitis Coalition. And I heard that DC is looking to start one as well. So that's pretty much the HBI story and how we leverage, you know, their community resources, as well as tap into other, you know, infectious disease areas to kind of supplement the work that we do for hepatitis B. COVID pandemic was quite interesting for us as well, because as you know, it limited the ability for us to do in-person community outreach. So we had to adapt a hybrid model where we could start the screening process online, call individuals to assess their needs. And then if they did not feel comfortable coming to a community event or in-person community event by a schedule, we gave them the option to go to a LabCorp of their choice by giving them a lab slip. But once they get screened and tested, we make sure that we also do follow-up and linkage to care as well. And so that's a huge part in what we do, because we don't have a clinic, is to make sure that we're not just screening and testing, but we are following up and linking them to care services, making sure that if these individuals could not afford medication, that we would tap into those patient assistance programs as well. So if you have any questions about HBIDC, what we've done, how we've done it, or what we are doing, please feel free to put it in the Q&A, and I'd be more than happy to address those questions. Thank you. I'm going to hand it over to Allison now.
Thank you, Amy. How's it going, y'all? My name is Allison Gay, and I'm a senior manager at NASTAD on the drug user health team. My primary role here at NASTAD is on our Strengthening Syringe Service Program response to COVID-19 grant making program. So while that's a COVID-19 grant making program, we do view it as a demonstration project. And so it does connect to adult vaccinations more generally. So a little bit about how we're doing that. So currently we fund 58 syringe service programs across the US and Puerto Rico to support the integration of COVID-19 testing as well as vaccinations at their community level. And so, we've taken a really broad view of this though, and that's how it connects to other vaccinations. We know that the services provided by syringe service programs are so interconnected, right? Like by supporting the day-to-day operations, the staffing, supply purchasing, and other things that SSPs need to do their services, we strengthen those relationships within their community so that they can effectively run adult vaccination programs. without that community buy-in that a syringe service program can offer, you can hire a small army of nurses, you could back the whole bridge truck up to the program, but you're not guaranteeing that the jabs are going to get to the arms of people who need them. And so one of the ways we also look at this is through funding for future-proofing and shoring up previous services. So we know that, we're in this new normal of COVID, and that this is unfortunately not going to be a transitory or transitionary pandemic, but that by funding the staff, funding, refrigerators, mobile units, and other supplies and infrastructure, we allow those programs to not only offer COVID-19 vaccines, but also build out their hepatitis A and B vaccines. We've seen programs do some really, really great and innovative work with being able to strengthen that relationship that they've built with the COVID vaccine programs to then use that as kind of a foot in the door and a connection point with their health departments to acquire those other vaccines that their communities, are seeking, and that many folks in communities served are at the highest risk for. Personally, I've managed a large syringe service program in Louisiana. I served as the first syringe service program coordinator for the Louisiana Department of Health and oversaw our direct syringe service program funding. I'm now a grant maker for syringe service programs nationwide, and I'm a person who uses drugs myself. So I've seen the facets of this, right? And there's so many gaps, but also opportunities that we can really build on. Some of the really exciting things that we're seeing with our COVID-19 grant and our programs, especially in our Center of Excellence. So of our 58 grantees, 8 of those are Centers of Excellence for adult vaccinations. And so we've seen them be able to, as I said, purchase or equip mobile units and build out their community-based services by adding vaccinations to that. But one thing that we're hearing time and again from those programs, especially around hepatitis vaccines, is the challenge around the acquisition of the vaccines themselves. So we're funding, the nurses, the staffing, the outreach and outreach materials, swags and incentives, but the programs still struggle to purchase the vaccines or struggle to make the connections at health departments to acquire the vaccines. And so we see this kind of patchwork depending on the state that folks are in. But one of the best things we've seen in the gold standard is when health departments can step in and provide vaccines to the SSPs themselves to directly provide those jabs. I mean, Cass was saying it before, right? Like how important it is to have people who have that harm reduction buy-in, who have built that trust and rapport with community, to be on site so that folks know who you are when you're offering them something like a vaccine. And especially with so much misinformation that we're seeing around vaccinations, we're seeing that need even more so than years ago with hepatitis. And so then, another way that we're seeing programs try to fund or acquire vaccines is through billing insurance. But as Amy was mentioning before too, that's not always an easy or realistic process, right? Specifically through the lens of syringe service programs and people who use drugs, there's competing priorities and a lot of other things that are happening in our participants and communities' lives. And so, asking somebody to, not only sit down for the vaccine and any intake process that person may need to do, but also if there's a whole other step of getting that person enrolled in insurance. And, for many states in the South where I'm located, we have states that aren't Medicaid expansion. So even getting participants onto an insurance to cover that is a challenge itself. And so that can provide, or that can create kind of this big gap for participants where we see folks who are interested in getting vaccinated, who are interested in acquiring that, but just, the time commitment, the interaction with the healthcare system, which for many folks who use drugs can be a primary source of trauma, is something that we see time and again kind of place more barriers to services for folks. And so when we can see either the SSPs be able to build out their vaccine infrastructure so that they can provide the jabs directly, that's something that we're seeing great success with. But also when we see, like Cass was saying, a program where the health department or other provider can send staff or volunteers to the SSP, but especially with that view of community connection and buy-in, then we also see a streamlined process that can be really successful. And something I've personally seen at SSPs I've worked at myself, where in New Orleans, our syringe service program, or New Orleans Syringe Access Program, was able to partner with the New Orleans Health Department. And we were able to bring in their vaccine team of interns, volunteers, and med students, as well as staff, and train them up on harm reduction principles and what the service delivery that we were doing was, and connect them with participants and community members before they were able to, come in and set up shop. So even though that program was connected to a federally qualified health center, we had an insurance billing mechanism as well as a robust EMR. We saw that billing of vaccines themselves was not effective. But once we had those strike teams able to come in and have that streamlined process, we were able to make those connections with participants. We were able to check in, fill out the small amount of paperwork that they needed, get their vaccine, and then go and be able to follow up with those folks over time. Another really exciting thing that we're seeing within our COVID-19 grant making, one of our grantees, the Open Aid Alliance in Montana, has been bolstering their infrastructure around COVID vaccines. But with doing that, they're actually seeing an increase in their hepatitis B vaccines. So even though there's a lot of challenges in getting folks vaccinated for COVID now, in where we're at in that vaccine process, many of our programs say if folks aren't vaccinated yet, the barrier to getting them vaccinated is growing, right? But we're still seeing those folks who are engaging with that program who are still really interested in getting Hep A or Hep B vaccines. And so we're able to see that increase, which is something that we're really, really proud of within this process. Another success story that we have within our grant cohort and our centers of excellence is Connecticut Harm Reduction Alliance, who previous to our grant had a really strong relationship with their health department, both state and local, but they didn't have the infrastructure themselves to be able to provide those vaccines. So what they were doing was connecting with health department, local hospitals, pharmacies to try to get folks in to be providing the vaccine on site. But as I was already discussing, there was those rapport building and relationships that can be challenging in that process. Also, something that outside of the harm reduction community can sometimes be missed is how important consistency is, right? People who use drugs, who are accessing syringe access programs, are unfortunately very used to programs popping up and then kind of receding, seeking something that you need, but after a few weeks it might disappear, or maybe it's not as consistent. Maybe it's once a month or once every other month, and that can be really challenging. So those are things that provide further barriers for folks who use drugs to get connected to vaccines. And so while they had that, Connecticut Harm Reduction Alliance had such strong relationships, they weren't able to provide that consistent service provision. So now that they've been able to bolster their infrastructure, purchasing new refrigerators, hiring new nurses and other medical staff, and really crucially, building out their EMR so that they can, streamline this process for participants, they're able to offer a wide array of vaccinations, and also just seeing that pay dividends now, where folks are coming to them. As much as 1 in 3 participants who are seeking information about vaccines, whether that is COVID or hepatitis B, or even flu shots. And now, as we're seeing with this infrastructure, and like I was saying, the future proofing of this, as we're seeing more demand and interest in monkeypox vaccines or need for monkeypox vaccines, that infrastructure is there, so that's something that can be easily added to the array of services programs are providing. I think with that too, I see that I'm already at the end of my time, and I want to make sure that we have some space for Q&A, because there are so many wonderful perspectives and speakers before me, and so I don't want to take up that time from folks to be able to ask questions that y'all might have. Thank you all so much for having me, and I think I'll kick it back over to Jasmine.
Awesome. Thanks for that, Allison. And thanks to all of our panelists. I'm actually going to hand it over to Cass. I see some questions coming through the Q&A box. So
yeah, thank you to all the panelists who've kind of been answering as we went, but I'll go through and look at some open ones, and then maybe we'll see if there are any other questions that have already been answered that panelists would like to add some more input to. So yeah, if you've got any questions right now, please feel free to put them in the Q&A box and we can address those. But I wanted to highlight Adrienne Simmons' question, which is, what advice would you give to an organization who would like to partner with their local or state health department? Who should they reach out to? Do they need to have a plan for an idea before the first meeting? Amy, thank you for answering that. And Amy said that they reached out to viral hepatitis coordinators in each state or to the local health department in question. Does anyone else, do any other panelists have anything they want to add to that? I just thought that was a great question.
I'm happy, this is Catherine, I'm happy to add a little bit as well. In each state as well, there are perinatal prevention coordinators, which are also really great places to start for hepatitis B. They do a lot of direct patient navigation for pregnant women who are pregnant people who are living with hepatitis B, and they work to prevent transmission from happening. So they're also a great resource to connect with your health department. The list of all the coordinators is on the CDC website too. And then just your local division of viral hepatitis is another great place to start. And you can also just ask them to join some of your coalition meetings or attend or volunteer at some of your screening or outreach activities. Or if you just want to connect about resources, I'm sure that they would be happy to do that as well.
Great, thank you. We also have Karen ask the question, and it was, for the Philadelphia program, how is the screening for Hep B done before giving a first dose vaccine?
Yeah, that's a great question. We try to control the flow within our events. And so we'll do the screening first, and we'll just make sure that we're monitoring every person who does screening and checking in with them before they move to the vaccination, because if they get vaccinated before the screening, it will mess up the blood test results. So with our screening, we were knowingly over vaccinating people, and we were okay with that, knowing that it's safe to give people extra doses of vaccine. And so knowing that it's hard to get people to come back once you have them engaged from the community, we were willing to accept the fact that some of the doses would be wasted, but overall, majority of people who needed the vaccine got the vaccine, which is what our goal was. And that one dose is better than no doses of the hepatitis B vaccine and offers over 50% protection, which we're willing to take that as a win, knowing that we would potentially not we would be vaccinating people who didn't need the vaccine, and making sure that within our letters, it's very clear what their test results mean, and providing our information as a resource if they have questions was really important for us for the linkage to care aspect.
For HBI, I just want to say that we usually screen and test before we recommend vaccination. It's for us, that's our process internally. And the vaccination, we usually try to refer to a provider that makes it either free or affordable. So just because every jurisdiction is different, and we work in multiple jurisdictions, we try to link them to the best option that they have.
Great, thank you. We have another question that came through. Oh, can the resources or contact information be shared? Yeah, so if you're talking about the slides and the contact information of the panelists, I think there'll be a follow-up where we'll get that information out. This webinar is being recorded.
Cass, if I could go back to Adrian's question about connections for
Yeah.
vaccine, because I wanted to look at it from another, such a great question, and from the CBO perspective, one that we hear a lot. But looking at it from the health department angle, I think is really important too. So my background, as I mentioned, was around syringe service programs and harm reduction providers. And oftentimes these programs, their main point of contact is in prevention departments of health departments. So the STD, HIV, and for some hepatitis prevention programs. So it's really important and I still consider myself a bureaucrat. So for us bureaucrats to be breaking down these silos between, our kind of STD, HIV prevention programs, as well as immunizations. And especially in my experience, a lot of times we're in the same bureau, but we don't always have those kind of strong relationships. And so it's really crucial, especially as we think about this. We've been doing a lot of work within harm reduction communities to start breaking down the silos between public health and behavioral health and single state agencies around overdose. But for adult vaccinations and those services, it's so crucial for us to be reaching across the hall to folks outside of our office, but in the bureau or in other aspects of the Office of Public Health, so that we have those connections when programs come. I mean, I think all of us know that people who use drugs are at a significantly higher risk for, hepatitis generally, but hepatitis B also specifically. And so making sure that we're able to kind of do some of that legwork first before the programs come, because once we do see rising cases or the outbreaks, we need to be able to mobilize quickly. And so a lot of that work can be done on the front end and really future-proofing those services.
Thank you, Allison. I appreciate that perspective.
I actually have a quick question if I can jump in. So we know that we have universal Hep B immunization recommendation now. And we also know that there's a lot going on in the immunization space, especially with health departments regarding COVID and a bunch of other recommendations that have been made. So do you think that the universal recommendation could be an opportunity for perhaps maybe newer organizations who are looking to kind of get their foot in the door with Hep B and make relationships with the health department? Will that be a great opportunity? Or is that something that might be a little bit more difficult considering everything that's going on? And have you guys run into any specific challenges perhaps with the immunization aspect of collaborations with the health departments?
It's a great question. I think the universal recommendation is definitely for collaboration.
Sorry, I think your audio sound is going in and out again.
Sorry, that's my connection. Well, let's see. Get better. No. Someone else.
I'll jump in, Catherine. I do think that the universal vaccination, universal screening is a great opportunity for community-based organizations and newer organizations or groups that want to help promote, screening, testing, and vaccination of hepatitis B. I think anytime that there are official guidelines out there and recommendations out there, it makes our job at the community-based level much easier in terms of sharing that message. And especially like having these elimination plans, I get really excited about the viral hepatitis elimination plans, because that's something that we can concretely say that, here's what the state has adopted that we need to take care of. And so it kind of gives you like instructions and permission to work on, hepatitis B initiatives. So I get really excited hearing that. And I think we should all fully utilize this opportunity with the universal screening and vaccination recommendations.
Yeah, and I'll just say really quickly, Allison already touched on it, but just within harm reduction services organizations specifically, I think one of the big barriers has been and will continue to be lack of rapport or maybe some mistrust around immunization, which doesn't come from nowhere. I think there are historically, good reasons or valid reasons for someone to feel hesitant, and so that is just kind of pragmatically a barrier that has to become overcome. And so locally, I've seen like vaccination teams that are smaller and full of people who already have rapport within the community, like going to the parks where people hang out and having tents where they're doing them there, and it's just like a more like casual or informal, trusting and like safe setting for that to occur.
100% agree with that. Yes.
And then the last thing that I'll say is, there's another question. I think we've got time for one more question. And it says, are there any federal resources that exist that organizations can leverage to better partner with their health department on Hep B work? And any you think should exist that don't? And so this says federal, and I'm not sure if that really specifically means federal or just national, but does someone want to chime in on that one before we wrap up here?
So Catherine's writing in the chat box that Hep B United has a federal grant. And so if you haven't already worked with Hep B United, you should reach out to them. And Angeline, you want to add in?
Yeah, Hep B United. It's a coalition, as they mentioned earlier, across the United States that you can go on their website, find a local partner there, and I think they can probably help you connect with your health department. And they also have a ton of resources as well. In terms of advocacy and policy too.
All right, thank you. Michaela, I wasn't sure what we had for wrap up, so I wanted to make sure that there was just a good time check. There are two more questions in the chat, I think.
I think we have time for one more, and then I can just close this out.
Okay, great. This says, what do you think about the idea of decentralizing Hep B in Hep B BD in hospitals by having them kept within the pharmacy? So they are currently pushing for this because they believe this will increase uptake in Nigeria.
I don't think this is going to work.
I can hear you.
Is it working? Oh, good. I'm so sorry, guys. So I think that this is a question specifically about hepatitis B birth dose. And I think it's more, so birth dose, because births in the United States mostly take place within hospital systems or birthing centers, for example, where vaccination is administered within the setting. I think it's in the US, it's not necessarily needed to decentralize that because it's working very well. Our perinatal hepatitis B prevention efforts are really strong. When you look at it internationally, I think there is an opportunity potentially to expand access to birth dose, not only, and this is getting more international, but like thinking about traditional birth attendants and home births and expanding access there is definitely is an opportunity. But I think there are lessons that can be learned from the US infrastructure that's been in place for perinatal prevention that can be applied internationally potentially.
All right, I think that is all the time we have as it is now 2 o'clock. So I just wanted to say thank you so much to our wonderful panelists. I think we had a really great and robust discussion, and I think we learned a lot of ways that we can all collaborate with health departments, and health departments can collaborate with us to really increase hepatitis B prevention across the US. So thank you so much for joining. On this slide, you can just see a few different ways to contact us and find more information. As we noted, all the resources and links will be shared, as well as the panelists' contact information. So if you have any additional questions, please do not hesitate to reach out. You can reach out to me or the panelists themselves, and we'll be happy to answer you. So thank you so much, everyone, for joining today, and I hope you have a great rest of your day.